and then we'll fill out the rest of it. Basically, we'll just confirm that we did the swear in today.
Me too, John, right?
Sorry.
Me too.
Oh, yes, sorry.
Yeah,
Jeez.
No problem.
Awesome. So yeah, and then we'll fill out the rest of it, and then me and my colleague Paris, who's witnessing, we'll sign it and then make sure it's part of our records and we'll share it with you guys as well. Go ahead, if those folks can please stand up and raise their right hand for me and repeat after me. We'll do it in unison. So, I state your name.
I, James Bowman,
Do solemnly swear
do solemnly swear
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Commonwealth of Massachusetts
to the Commonwealth of Massachusetts,
and will support the Constitution thereof.
will support the Constitution.
So help me God.
So help me God.
I state your name.
I state as well.
Do solemnly swear and affirm
Do solemnly swear
that I will faithfully and impartially discharge
that I will faithfully and impartially discharge
and perform all the duties incumbent on me
and perform all duties incumbent on me
as a member of the Health Policy Commission,
as a member of the Policy Commission,
according to the best of my abilities and understanding,
according to the best abilities and necessary,
agreeably to the rules and regulations of the Constitution
agreeably to the rules and regulations of the Constitution
and the laws of this Commonwealth.
and the laws of this Commonwealth.
So help me God.
So help me God.
I state your name.
I state as well.
Do solemnly swear that I will support the Constitution of the United States.
Do solemnly swear that I will support the Constitution of the United States.
Awesome. Round of applause. Awesome. But I think if everybody signed those that. Here.
Good afternoon. Welcome to the Health Policy Commission's September meeting. This is an important day for us since it's the first meeting of the new board term. I want to welcome our new and returning commissioners and also those tuning in on the live stream. The legislature put forward and Governor Healy signed healthcare legislation that focused on drug costs, primary care, oversight of private equity in healthcare, and protecting the state from predatory actors. The legislation gave the HPC new responsibilities and also restructured the board with every one of us, the commission members, newly appointed or reappointed in July. I want to thank the governor and the attorney general for their appointments of all commissioners, including me, and thank each of the members for their commitment to serve the Commonwealth. So this meeting is the first of our newly appointed board with expanded responsibilities for the HPC to address the critical challenges in healthcare that were also the focus of the legislation, including the new realities that are making affordability and access harder. Each of us have been appointed for different perspectives and experiences. We'll each introduce ourselves in a few minutes. But we share a strong resolve to advance the HPC's mission for all Massachusetts residents, despite both the known and the new threats to progress. I serve in the seat designated for a chair with experience in healthcare administration, finance, and management at a senior level. I have served for 3 years and, as I said, was just reappointed. I'm grateful to live in Massachusetts and to have spent my career working in the healthcare system in Massachusetts. And I look forward to serving and collaborating with all the commissioners to strengthen and protect the system. So with that as an opening, let me just review our plan for this afternoon for our meeting, and then I'll ask each of the commissioners to introduce themselves and their role on the commission. So first, we're going to have a briefing of the Massachusetts open meeting law from the Office of the Attorney General. And then we will review to approve the HPC's bylaws, which were modified and will be explained by our general counsel. And then we'll take a vote to nominate and appoint a vice chair of the HPC board, which we do every year. Director Sells will then share highlights of the HPC's 2025 policy priorities and the agency's agenda for the remainder of the year. We'll take a quick break around 2:30. And when we resume the meeting, we'll hear an update on the material change notices received since the last convening of the HPC board. And then we'll conclude with agency updates in the executive director's report. So we do have a plan to review the open meeting law at 1 o'clock, but I want to start by having commissioners introduce themselves, and then if we need to pause in that, we can. We'll ask each member, both new and continuing commissioners, to introduce themselves, explain the role that they were appointed for on the HPC board and their professional background. So if I could start with Commissioner Cotterell.
Good afternoon. My name is Sandra Cotterell. I'm in the seat designated for a nurse. I have worked, my nursing career is taking me through different sectors. I started off working clinically as a surgical nurse and cardiothoracic nursing before transitioning to the managed care side, where I served as an executive for a startup health maintenance organization, where I oversaw the care management and utilization management arm of the health plan. And then the last 30 years of my career was spent in community health, where I served as the Chief Operating Officer of the Codman Square Health Center, and then ultimately the CEO of the Codman Square Health Center. I am Boston born and raised and have lived in the Commonwealth all my life, and looking forward to taking that background and experience to support the with its initiatives and efforts. So I'm looking forward to working with everyone in that context. So thank you.
Terrific, thank you. Commissioner Erickson?
Keith Mersley Erickson. I was appointed by the Attorney General as the health economist. I'm a longtime Massachusetts resident. I'm a professor and department chair of markets, public policy, and law at Boston University. A co-editor for the Journal of Public Economics. I studied health insurance markets, including some early papers on the Massachusetts health reform, as well as the Affordable Care Act and the Medicare prescription drug benefit, and I have studied the organization of healthcare delivery, how firms contract, negotiate.
Welcome. Thank you. Commissioner Liebman?
Thank you, and good afternoon, everyone. Chris Liebman, and I am serving in the seat for an individual with expertise in healthcare innovation, including pharmaceuticals, biotechnology, or medical devices. My formal training is in biology, pharmacy, pharmacoeconomics, and outcomes research. And I've spent a little over the last 25 years in the innovation sector in pharmaceutical or biotechnology, from very large companies to very early startups. My interest in serving on this and my real privilege and honor to be here stems from that work. And I also now live in Massachusetts, like all of us here, but I live here with a lot of purpose in that I grew up in Illinois. My family and I, my wife and I and kids lived in a number of states around the country and in other countries outside the US. But we live in Massachusetts now because this is a very unique ecosystem, and Boston, Cambridge, and the broader Massachusetts has become the center of the innovation and biotechnology universe in many ways. And that's very unique. And living in many other places around the world and working on developing new medicines for conditions at the earliest stages of childhood asthma to immunology indications such as multiple sclerosis to some of the biggest challenging areas in society of Alzheimer's and dementia. I've seen one commonality, and that is We all need and want new innovation. But we all recognize that we need to do this in a sustainable way. And that's why it's a real privilege to be part of this group and supporting the Commonwealth and looking forward to being part of this.
Thank you. Welcome. Commissioner Walsh?
Good afternoon. My name is Steve Walsh, and I have been, I'm serving in the seat representing hospitals and health systems, named by Governor Healy. And it is a true pleasure and honor to be here. The pen I used to sign the appointment letter today was the pen that Governor Deval Patrick used on the D in his name when he signed Chapter 224, a bill that I authored with colleagues 13 years ago. And it is such an honor to be able to come back later on in one's career to help work on, perfect and evolve a law that I care so deeply about. And so I thank Governor Healy for this awesome responsibility and look forward to working with David, Colleen, and fellow commissioners to continue to build upon the best system that we have in the world.
Thank you. Commissioner Calcio?
Thank you, Chair DeVoe. It's an honor to be here. I'm Michael Caljo. I'm the Massachusetts Insurance Commissioner. I was appointed by Governor Healy last October to take on that role. And I'm enthusiastic and frankly honored to be here in this great group, rolling up our sleeves to get to work on the challenges that we have ahead of us. I was like the other board member, born and raised in Boston as well, lifelong resident there and a lifelong resident of the Commonwealth. And I come to this role with 35 years of private sector and public agency, public policy experience. I think one of the reasons why I'm excited to play this role is understanding the need for balance and balanced approaches in terms of the work that the Health Policy Commission does. And I look forward to working with all of you towards those tasks ahead. Thank you.
Thank you, Commissioner Caljo. And to complete the introductions of the new commissioners, I wanted to mention that Commissioner Kirkpad, who was unable to join us today, was appointed by Governor Healy and serves as the board member with demonstrated expertise in health plan administration and finance. He most recently served as the Chief Financial Officer, Point 32 Health, until his retirement in June 2023. So now we'll turn to the introductions for returning commissioners. Commissioner Cohen?
Thanks, Deb. I'm Marty Cohen. I was reappointed by Attorney General Campbell for the behavioral health seat on the commission. My career has been focused on mental health policy and also healthcare philanthropy, and recently retired as after 25 years as the president and CEO of the Metro West Health Foundation, and also a lifelong Massachusetts resident.
Thank you. And Christopher Harding, who's here for Secretary Mahania.
Thank you, Chair DeVoe. My name is Chris Harding. I am currently the Chief of Staff and Undersecretary for the Executive Office of Health and Human Services. I'm here representing Secretary Mahania. I also formerly served as the Commissioner for the Department of Revenue, so I definitely bring a fiscal eye to things, which is always a good thing. I am not a lifelong resident. I've been here almost 35 years. Originally from Scranton, Pennsylvania, came here to go to Boston College and really fell in love with the place. So I consider myself pretty much a native now. Most of my career has been in the private sector and really focused on consulting around strategy and tech, much of that in healthcare. And as all of us know, the last 25 years in healthcare has been greatly supported, at times slowed down by tech. And I have been a key part of a lot of that, electronic health records, adoption, et cetera. So it's something I'm pretty passionate about. I came in with the administration and originally Secretary Walsh, who recently stepped down, and I have stayed on with Secretary Mahania at this point. And thank you. It's an honor and a pleasure to be here.
Thank you. Additionally, Dr. Alicia McGregor, who was unable to join us today, was reappointed by the Attorney General to her role as the board member with demonstrated expertise in healthcare consumer advocacy. So glad to have the opportunity to serve with you all, and we're officially launched. So shall we move to the bylaws section, or we do have that, we're ready for the meeting law? Okay, perfect. Let me introduce, oh, I didn't see you. Great, welcome. Carrie Bennington from the Office of the Attorney General, who's going to provide us with an overview of the Massachusetts open meeting law. Thank you.
Thank you, Chair. It's really an honor to be here and to be among such esteemed company. So thank you for inviting me. I'm here to give a very brief overview about the open meeting law. The open meeting law is a law, of course, enacted by the legislature, and enforcement authority of the open meeting law is vested in the Office of the Attorney General, and specifically the Division of Open Government, of which I'm the director. And one of the things that we do in the Division of Open Government is trainings and outreach. And so what I'm going to do today is just about a 10-minute overview of some key requirements of the open meeting law that would apply to a board such as this. This is not intended to and cannot possibly be a comprehensive training on the open meeting law, but we do offer those trainings twice a month as webinars at different days and times. And so for anybody who is interested, I would encourage attending a more comprehensive training on the open meeting law. But I'm here to provide some overview of common points of concern and some of the key requirements. Do I have the clicker? Or, oh, there it is. Perfect. Sure. Okay, so to start off, there is no specific training requirement within the open meeting law. You may be familiar with the training requirements in the conflict of interest law and elsewhere. What the open meeting law has instead is a certification requirement. And so any new commissioner is required to complete a certification form within 2 weeks of being appointed to their role. So if that has not already been done by anybody, just please be aware that there is a certification requirement, and we have more information about what you are certifying. So I'll start by flagging that. What I'm going to talk about today is just the basics of the open meeting law. So key requirements, mainly that notice be posted for all meetings, that deliberation, and I'll talk about what that is, needs to happen in a way that is open to the public unless there is a permissible purpose for convening an executive session. There are requirements as to meeting minutes, and there is an open meeting law complaint process that I won't go into detail about, but I should just mention that it exists, and any person who believes there has been a violation of the open meeting law can file a complaint with our office for investigation. So before we get into that, I just have to mention who is subject to the open meeting law's requirements. The open meeting law applies to public bodies, and the legislature defines public bodies broadly as any multiple member board, commission, committee, notably specifically says subcommittee. So there is no question that this board is a public body subject to the open meeting law. The key thing that I want to mention is that subcommittees that may be created as standing committees or ad hoc are also considered public bodies that need to comply with the open meeting law. So even if a subcommittee itself includes less than a majority of members of this board, a subcommittee that was created to advise or make recommendations back to this board also needs to comply with the open meeting law, meaning it also needs to post notice and make sure that its discussions take place during noticed meetings. So now we know who is subject to the open meeting law. The next thing to discuss is what communications are subject to the open meeting law. The open meeting law says that deliberation is any communication through any medium that is between or among a quorum of the members of a public body on a matter within its jurisdiction. A quorum is a simple majority, and that's a simple majority of the number of seats on the commission. Even if there happen to be vacancies from time to time, the quorum does not change. So any deliberation really refers to just about any communications that are between or among a quorum. So one word of caution is communications that might happen in a serial manner. One thing we see sometimes, which is inappropriate, would be for a chair, for example, to one-on-one speak with each member and say, I'm considering proposing this. Would I have your support? Even communications like that might happen in the moment among less than a quorum of members. If the same communication effectively reaches a quorum in a non-contemporaneous manner, that also is considered deliberation and should happen only at a posted meeting. Deliberation, as the legislature has defined it very broadly, is not limited to opinion communications or decision-making communications. It really refers to all communications, even just the sharing of information. There are some administrative exceptions. So it is permissible to have communications outside of a meeting for purposes of scheduling a future meeting or for proposing agenda items. It's also permissible to share documents that may be discussed at an upcoming meeting, provided that none of those communications convey an opinion of any member of the commission. So it's just important to know that deliberation is very broad, and so we caution in particular the use of email communication among a group that would include or that could reach a quorum. So I just mentioned some of these things that are not considered deliberation. And again, I'll emphasize that communications that do not involve or reach a quorum and that also are not a quorum of a subcommittee are not subject to the open meeting law's definition of deliberation. And so it is perfectly permissible for, let's say, 3 members of the commission, as long as they are not all on a subcommittee and constitute a majority of a subcommittee, but for 3 members of the commission to engage in something outside of a meeting, to talk about an issue that is of common concern, and then to request to be put on an agenda for future discussion, to propose an idea, something like that. So as long as a group is not a quorum of the full commission or of a subcommittee, those communications are permissible. It also is permissible to have communications that are from somebody who is not a member of the commission to the full commission. So for example, a member of the public is welcome to send an email blast to the entire commission. Commission members just need to be careful not to respond, not to reply all in a way that they might reply and share their opinion and then reach their fellow commission members. Similarly, staff frequently will need to share information with the commission. And again, they are welcome to do that. Just be careful of the reply all, which can cause concerns. So all deliberation of a public body needs to take place only during a meeting for which notice has been posted and that is open to the public. This includes any sort of meeting, whatever you call it. If it is a communication among a quorum, it is a meeting and needs to be posted. So that includes things like special meetings, retreats, workshop meetings, meetings that are called just for one particular purpose. Anything that would include communication among a quorum on a matter within your jurisdiction is considered a meeting, no matter what you call the meeting. I do want to just take a minute to talk about accessibility at meetings. So this includes a lot of different things. This meeting, of course, is held in person. For meetings that are held remotely, it is very important to ensure that there is clear audio. The open meeting law does not require that video be used, but it is strongly recommended by the Attorney General as it enhances the ability of the public to follow the discussions and who is speaking. But if there is a remote meeting or a hybrid meeting, make sure that the audio is very clear. Meetings that are held in person need to be held in ADA compliant locations. There need to be reasonable efforts to accommodate crowds. If you were to have a meeting with a particularly controversial topic and you expect that you might have hundreds of people in attendance, a larger room would be required. And then additional accommodations may be required if somebody were to contact the commission and say that they wish to attend a meeting but need additional accommodation. So now I'm going to talk for a couple of minutes about the requirements for meeting notices. Notices need to be posted of every meeting at least 48 hours in advance of the meeting, not including weekends and holidays. And the notice needs to include the date, time, and place of the meeting. as well as a list of topics that are reasonably anticipated for discussion. And that's what I want to focus on just for a minute. The whole point of the open meeting law is that the public needs to have access to the deliberations of public bodies. And the only way for that to be meaningful is if there is adequate notice to the public, not only that a meeting will take place, but of what topics are going to be discussed. So what we say as a rule of thumb, and we recognize it's somewhat subjective, is that the list of topics on the meeting notice need to have sufficient specificity that a person can make an informed decision about whether the topic is of interest to them and make an informed decision of whether to attend the meeting. People don't have endless capability to attend every meeting. And so really specific meeting notices are key to carrying out the open meeting law's purpose. We do have a lot of guidance and a lot of examples as to what sorts of topics are specific enough. And I won't take the time to go into detail there, but I do just want to highlight that this is really important. And the most common violation of the open meeting law that our office finds year after year is meeting notices that do not list the topics with enough specificity. So that is something that we consider very important from an enforcement standpoint. Now, the only exception to the requirement that deliberation take place during a meeting that is open to the public is in situations where an executive session is permissible. The open meeting law lists 10 permissible reasons to convene an executive session. And we do have guidance on what those 10 permissible reasons are. But it's important just to note that in order for a matter to be discussed in executive session, it has to really fit within one of those 10 purposes. There is no catch-all for things that seem sensitive or seem deserving of confidentiality. If it doesn't fit within one of the 10 listed purposes, then it needs to be discussed openly. There are some procedures also in order to ensure transparency if there will be an executive session. So again, we have some guidance on those, but I won't go into detail. And then the last thing that I'll talk about is meeting minutes. The open meeting law does require that minutes be prepared of every meeting. The minutes need to be created and approved within 30 days or the third meeting thereafter, whichever is the longer period of time. So if you meet monthly, you have 3 meetings until the minutes need to be approved. The minutes need to include a summary of the discussion on each topic, and the summary of the discussion needs to be detailed enough that a person who wasn't at the meeting could read the minutes of the meeting and have a general sense of how the discussion unfolded, what sorts of matters were considered in reaching a decision. So it's important that meeting minutes include more than a statement that a discussion took place on a specific topic. It needs to include a summary of that discussion. Now, minutes do not need to be a transcript. They don't need to include every remark that is made by every person. But in general, our guidance is that if there's kind of a majority view and a dissenting view, those views should be captured in the minutes. The general topics or concerns that were raised should be captured in the minutes, although it doesn't need to say exactly who said what or who expressed what concern. And then I'm going to wrap up just by letting you know what resources the Attorney General's office has related to the open meeting law. So on our website, we maintain a very robust website with information and resources. A couple of things that I'll highlight is that we do have an open meeting law guide that we update pretty frequently, and it's really a plain language explanation of the requirements of the open meeting law. We have a lot of frequently asked questions. One thing that can be very helpful is that we have just created a bunch of checklists. So for example, there's a checklist for preparing a meeting notice, a checklist for the steps to entering an executive session, a checklist for meeting minutes, and some other things. And then all of our determination letters, our opinion letters resolving complaints, there are about 2,000 of them at this point, but they're available in a searchable database if anybody really is looking to do research. And the last thing that I'll mention is that you are welcome to contact our office. The Division of Open Government has a rotating attorney of the week who is available to answer emails and phone calls if there are any questions about what sorts of things are permitted by the open meeting law or what the requirements are. So with that, I will conclude. I don't know if there's time to take a couple of questions, I'm happy to.
Sure. Yeah.
Okay, so if
absolutely.
anybody does have questions, but otherwise, like I said, our contact information is available for you.
Doesn't look like any questions. Very clear. Thank you so much.
Thank you again for inviting me. We really appreciate it.
Absolutely.
Thank you.
Perfect timing. And before we move to the bylaws, my mistake, I realized that we skipped over intros for Commissioner Wilmoth and for Executive Director South. So could we ask you, Commissioner Wilmoth, to take a step back and
Sure.
introduce yourself? Thank you.
I did introduce myself at the June meeting, because I was originally appointed by the state auditor back in April. And then happy to have been reappointed by the governor, in July, I guess. So I was appointed as I'm gonna read my title here, expertise in representing the healthcare workforce as a member of the labor organization. That's been my experience since moving to Massachusetts in 2001. After school, worked in politics here a little bit and then joined the union on union staff in 2008. So I've worked there now close to 18 years. My title is Senior Policy Analyst. I do sort of healthcare policy, research, writing, lobbying for the organization. And I'm happy to be here to represent not just my organization, but the entire healthcare workforce. And their interests as both care providers, but also as consumers of healthcare. They definitely have a lot of interests in both areas. So I'm happy to be here to represent those interests on this board.
Thank you so much. Thank you. And Executive Director South.
Hi, good afternoon. I'm David Seltz. I serve in the role of Executive Director. I was originally appointed into this position by the Board of the Commissioners 12 and a half years ago, and have been serving in this role ever since. It has been an honor to serve in this position and to see this agency grow from a few staff to now a staff of 65. And we'll be talking a little bit later about all of the work that we're up to.
Thank you. Perfect. So we'll now move to the next agenda item, which is to review the Health Policy Commission bylaws. I'll turn to Lois Johnson, who's the Health Policy Commission's General Counsel. And after Lois has reviewed the bylaws and any discussion, we will be asking the commissioners to vote to approve the bylaws.
Thank you, Chair DeVoe, and thank you to all the commissioners new and returning. And just a note on the open meeting law presentation we had, we will be sending around for all the commissioners the open meeting law certification that Carrie referenced. So following this meeting. But I'm here to talk about for your adoption, the bylaws of the Health Policy Commission. The bylaws are the internal rules that govern the operations of the commission. They're intended to complement our statute and regulations, as well as other applicable laws, including the open meeting law. They set forth the respective roles and responsibilities of commissioners, the chair, the vice chair, and the executive director, and provide really the rules of the road for how the business of the commission is transacted, from scheduling and conduct of public meetings to the hiring of employees and execution of contracts and other instruments. Just to note, the bylaws include the fact that a quorum is 6 commissioners, so that's pertinent to the open meeting law. The bylaws were first adopted by the inaugural board of the HPC in December of 2012, and were based at the time on those used by other public bodies in Massachusetts, including the Connector Authority. And the bylaws that you have reviewed and are before you today are substantially the same as that 2012 set, but do include some important updates that I want to highlight. So first, the bylaws now incorporate the current agency mission. They provide for the implementation of the new commissioner stipend provided in Chapter 343, the new healthcare law. They incorporate confidentiality and data security requirements for commissioners that align with the agency's written information security program that applies for employees. The requirements for board meetings that are incorporated in the bylaws have been simplified, but also made consistent with the open meeting law, such as allowing for remote meetings. And finally, the bylaws authorize the executive director to execute contracts valued up to $500,000 annually with notice to the chair, and provide that board approval is required for contracts over that amount. The executive director has actually had that authority for specific contracts related to market oversight activities since 2013. And this change provides that administrative flexibility for other types of contracts as well. So I'll pause there if there are any particular questions on aspects of the bylaws. Great.
None, so we ready to move to a vote? And I'll just clarify that at in-person sessions, we'll do our votes by yay and nay or any abstentions. But when we meet on Zoom, you'll see that we'll go through a roll call vote, but just so that folks know the process. So let's turn to a vote to adopt the Health Policy Commission bylaws as presented. Could I have a motion? A second? Second, thank you. All in favor, say yay. And any opposed, nay? And any abstentions? Okay, thank you very much. Good. So our next order of business is to appoint a vice chair. And just to review for commissioners, each year, the board appoints a vice chair by a majority vote, and that vice chair serves for a one-year term. The one very practical aspect of being a vice chair is that the vice chair steps in to chair our meetings if the chair is not available. What I would like to do is nominate Commissioner Cohen, our current vice chair, to serve again for a one-year term this year. Commissioner Cohen was first appointed in 2015, and he was appointed vice chair in September of 2019. And I'd like to nominate him to continue. I did ask if he is willing to serve, and he is. And in each year that I've asked him this, his answer has been, I am willing to serve unless there is someone else who would like to serve. This year, given that all but two of our members have served for less than a few months, and the Commissioner Cohen is the most experienced of those who are reappointed, I am proposing that we ask him to continue. And obviously in future years, anyone can nominate another step forward to also serve as potential vice chair. Any questions about either the process or about Commissioner Cohen? Yes, he's is always wishing my good health. I want. So far so good. I can't wait. So if I could turn for a motion to vote, and let me ask for any abstentions to the vote. I think he wanted to abstain. So Commissioner Cohen will abstain. So for a motion to turn to a vote, thank you. And second, thank you. And all in favor say aye.
Aye.
And opposed, nay. Any other comments? Okay, great. You're on for the next year. So we'll now turn to Executive Director Seltz, who's going to outline the 2025 policy priorities and agenda for the HPC.
Wonderful. Good afternoon. And congratulations to the new members of the Health Policy Commission Board. Welcome to the HPC offices, and specifically welcome to the Stuart H. Altman Conference Center. You are joining a select and prestigious group of private citizens who have been chosen to serve the public by being a member of this HPC board and working together with each other and with staff to advance this important mission of making healthcare more affordable in the Commonwealth. Thank you for your service. I'm joined here today by my co-leader at the Health Policy Commission, Deputy Executive Director Colleen Elstermeyer.
Hello, everyone. Welcome. I am Colleen Elstermeyer. As David just said, I'm the Deputy Executive Director of the Health Policy Commission. I have been in this position for 12 and a half years also. We're just thrilled to welcome you all today. And I just wanted to say on behalf of the staff, our 65 staff, we are so excited and energized to work with you all, learn from you all, and move forward with the new iteration of the Health Policy Commission. It's a really exciting time for us as staff. So welcome and thank you.
This is a really exciting day, as Chair DeVoe said at the beginning, a historic and important day. It does feel like a new day and a new era for the Health Policy Commission to have this new board, these new responsibilities, and we're really excited to get to work. The work is important, the work is daunting, the challenges are real, but there's just such a fresh energy, and we're excited to get to work. I also do, as Chair DeVoe did, I want to really thank the governor's office, the attorney general, for their role in appointing such incredible people to the board. Also, Speaker Mariano and Senate President Spilka also had a role in making some nominations for some of the board members, so thank them as well. This is really a stupendous board. For this particular agenda item, since we have 7 new commissioners here, and I suspect a lot of members of the public who are tuning in to see and to hear from this new board, what I really want to do is orient you to quickly just kind of the mission and background of the HPC, talk specifically about that new legislation that expanded the HPC's authorities and reshaped the board composition, tell you a little bit about some of the important developments that have happened so far this calendar year, and then give you a sense of what I expect some of our policy priorities are going to be and ongoing activities for the rest of the calendar year. So I prepared a number of slides and we'll walk through this, but I really do hope that this can be a conversation. So please interrupt. I will never be offended or give me the head nod. I will stop, ask questions along the way. I really hope this can be a discussion. And I want your feedback, your input. That makes the work all the better. To just dive right in and just to go all the way back to 2012, as Commissioner Walsh said, this Health Policy Commission was established by a comprehensive piece of legislation that was passed by the legislature and signed by Governor Deval Patrick. The legislature and the governor understood that the rising cost of healthcare was unsustainable. And it was unsustainable for both government, it was unsustainable for the businesses and small businesses of the Commonwealth. Most importantly, it was unsustainable for the families and residents who live and work here. And so the legislature came together and with major parts of the healthcare industry and community, with consumer advocates and business advocates, helped craft a first in the nation approach to bending the healthcare cost curve. And part of that effort was setting a measurable target for sustainable healthcare cost growth, or the healthcare cost growth benchmark. This was the first time a state had done something like this, to have a measurable target for all healthcare expenditure growth. And to help guide and monitor this effort, the legislation set up a new independent state agency that would have the objective data and the professional staff combined with expert commissioners to be able to help guide and inform the industry and the policymakers to be able to make sure that we achieve this ambitious goal. Importantly, as is seen here in our mission statement of better care, of better health, better care at a lower cost, the goal here was not to reduce costs at the expense of our other values of access, of quality, of having a world-class healthcare institution. There are many ways you can cut costs in our healthcare institution that would be antithetical to those values. What our goal here is actually to improve the health, to improve the care, to find those strategies that can create a more efficient, a more accessible, more high quality healthcare system. And I do believe that there are those strategies out there. This mission statement also provides some of our values, being objective, using data and evidence to guide our policy insights, and also that our work should touch all residents of the Commonwealth. We know that there are deep and historic disparities in health outcomes, and we are not going to be successful unless our work improves the health outcomes for all residents, regardless of race, ethnicity, income, and geography. When we think about how we try to do our work and capturing all of the very different statutory responsibilities that the legislature first provided for us in Chapter 224, this is how we've kind of bucketed them internally and how we talk about our work publicly. What are our levers for actually influencing change in the healthcare system? First is research and reporting. As you'll hear and begin to understand, and I'll show you later today in a report that we have on Hospital at Home program, we have a tremendous part of our staff is about analyzing data and using that data to help inform where we can see opportunities for cost savings, to use that data where we can understand where are the real cost drivers, and then being able to carefully craft the right types of solutions so that we don't have unintended consequences. We have access to some of the most robust data sets of any state in the country, and that is such a strength and a resource to be able to craft the right types of insights to drive policymaking. Second, we're a partner. We work directly with provider organizations to test and innovate different ways of delivering care. We have distributed over $100 million in funding, mainly to community hospitals, but also to community health centers and to other organizations around implementing programs that will address health-related social needs, that would integrate behavioral health care, that would use telemedicine and different types of technology to reach patients in different ways. And so through this, we gain learnings and we create an environment where we can work with provider organizations to help them sustain those innovations into the future. We're also a convener. We work to bring different interested parties together and to try to find solutions together. I think there is a humbleness here to say government doesn't always have all of the solutions. And there's always an opportunity to bring like-minded individuals and market participants together to say, we are all seeing the same problem. Can we find common solutions? One of the ways that we do this big convening is through our annual cost trends hearing. And we're going to be bringing a lot of people together on November 12th to talk about some of the big challenges facing our healthcare system and what common solutions we might be able to find. And finally, we act as a market monitor. We do understand that changes in our healthcare market have significant impacts on healthcare costs, quality, and access for residents. And those changes need to have some public examination. And so we play a role on behalf of the public of asking those questions and making those findings public so that the public and policymakers can understand when those changes occur, what do we think the implications can be? And can we help steer those changes in ways that will minimize negative impacts and maximize positive ones? So before I turn to the new legislation and some of our new authorities, I'll just pause here and just to see if there's any comments or questions just kind of on our basic history and kind of mission and work. And Deb, I don't know if you want to share any reflections or thoughts.
Yeah, I mean, what I would say is that prior to being a commissioner, I had the opportunity to experience the Health Policy Commission as a regulated, in a regulated entity. And I think the role that I did not appreciate as fully as the role of the HPC as market monitor, since many of the discussions that happen with individual entities that the HPC is monitoring don't have to rise to the level of, you know, intervention around a PIP or CMIR, but produce very productive results. So I think it's going to be important for us as commissioners to understand both the, you know, every one of these roles, but also the aspects of it that might not have been as evident to you in your previous interactions and knowledge of the HPC. But with that, other questions of David before describing our new responsibilities?
Yeah, thanks, Chair DeVoe. And a quick question, because I share the same sentiment, which is I've learned even in the last 60 days, I thought I understood the Health Policy Commission. And through my onboarding, I've learned that there's a lot more to what you guys have been doing for the last decade. So first off, congratulations on that. With the slide here and the core strategies, I'm curious with the legislation changes this past year, you know, how do you look at these four? Is there a difference now in how you will approach the amount of time that you dedicate the team towards these four, or are there areas that you see coming up different than what we've seen over the last decade?
Yeah, that's a great question. And I think one that I think will be one that I want to kind of continue to talk with all of you about as we think about what our core strategies will be moving forward and our core policy priorities are going to be moving forward. As I think about the new activities and the new responsibilities, I do think many of them fit actually quite nicely into these four buckets. There is, you know, one new activity that I think probably straddles all four of them, which is a new responsibility around state health resource planning. And this is a new responsibility around really trying to understand the supply and distribution of our healthcare services and making you know, some reporting and planning about the alignment or misalignment of those services and facilities and you know, making recommendations about how best we might align them. And I think that's both going to be obviously some data work that goes into that, but also going to need some convening work that goes into that and thinking about how we might talk to communities about what their perception of need for services is. I think there'll be some partnering work that goes into that and certainly understanding how market dynamics have driven perhaps a misalignment of services or drive closures of services in some areas is part of that. So I'm kind of speaking a little bit off the cuff to that question, Commissioner, but other than that, and as I get into the new activities, I think they do align well with our core strengths. And I think that is a reflection of the legislature understanding as they were thinking about our new responsibilities, they were building off of a strong foundation and said, here, we know HPC has these capabilities. How do we expand and grow? And I think that was a very strategic by the legislature.
Yeah, it's a good point that it's what the commissioner's making me think about is that maybe worth re-looking at this description to see whether we want to call out some of the new responsibility, particularly around health resource planning, more specifically in this, you know, description. Commissioner Cohen?
David, as you were talking, I was thinking about the critical role that HPC plays with other state agencies. I mean, we have lots of state agencies involved in healthcare, health systems planning, insurance. Could you talk a little bit, I think, for folks about those relationships, CHIA, DPH?
Yeah. Thank you, Commissioner Cohen. It's been really a priority and important to Colleen and I to have those really strong relationships with our other state agencies and understanding that through those relationships, we can have a impact that's bigger than just our organization in and of itself. So first and foremost is our relationship with the Center for Health Information and Analysis, CHIA. This was the agency that was also kind of reformed at the same time that the Health Policy Commission was created. They are the data hub for the Commonwealth. They collect and manage the all payer claims database. They collect and manage a lot of the hospital discharge data. I actually sit on the CHIA Oversight Council. And so there is, a cross connection, even in the governance structure. We are so tightly linked in terms of making sure and having an understanding, because we rely so heavily on the data that they collect, and that we need to be able to answer the policy questions that we have. And so there is a real, I think, incredible working relationship that needs to happen between the two agencies, and a partnership. I could go a long list of thinking of others. As I sit here today and I look across the room, I see, the commissioner of the Division of Insurance. Right now, the Division of Insurance has new responsibilities when it comes to oversight of pharmaceutical benefit managers. We also have some new oversight of pharmacy benefit managers in our law. And so as we think about these implementing new regulations and oversight, we need to make sure that we're having, similar, the same types of definitions and the same types of understandings, and speaking with stakeholders in the same type of way. The Department of Public Health is a critical ally in terms of our thinking about our priorities in primary care, our priorities in state health planning, our priorities that we've had in many of our grant programs that were focused on dealing with the opioid epidemic. During the pandemic, I worked for the COVID Command Center, and we had a team that we redeployed here from the HPC that worked essentially for the Command Center for about 2 years. So these relationships are deep and important, because we have incredible assets here. We have incredible assets in terms of our data and our people, and we're nimble and we're fast. And that's an ability that we want to be able to, be able to provide to our other sister agencies, and to be able to find those opportunities for partnership. And then, as I said before, to be able to have an outsized impact. Commissioner Walsh?
Thank you, Executive Director Seltz. As you think about the HPC's responsibility to the Commonwealth and how you're responding to this market in real time, how do you view what's happening nationally and any changes that you may be also having to encounter in the coming months, and how they fit into your strategic planning?
Yeah, it's a great question. Certainly, we are constantly trying to keep abreast of all of the changes that are happening, both in national health policy, CMS. As I think that is a challenge in and of itself, to try to keep track every day of the different types of rules, regulations, guidance, what this all means, and what the implications for Massachusetts are going to be. Oftentimes I rely on other organizations that are analyzing and looking at this, the Blue Cross Blue Shield Foundation, the Connector Authority, and some of their analysis, trying to understand the Mass Hospital Association, trying to understand what they are analyzing and thinking about in terms of potential loss of coverage, potential changes in the enhanced tax credits, what this may mean for our mass health program, and different types of administrative rules. I'm focusing a little bit on kind of the coverage, potential coverage changes and threats, and then the downstream implications for our healthcare, both our healthcare providers, but the residents of the Commonwealth, and how they're going to be experiencing healthcare. I think this is going to be an important conversation for us and this board, and an important conversation that I think will be a topic at the cost trends hearing.
Great. I've a couple of comments. One is, I think, when I look at the expertise around this table, I'm heartened by the fact that it's a combination of folks that have policy and government experience, and also an important amount of private market experience, and economic experience. And I think all of those are going to be brought to bear as we grapple with what I think is an even more difficult landscape than we've seen in Massachusetts for some time. To the question about agency collaboration and work, I think there are always more opportunities to do that. And I'm already really pleased by the amount of interaction between my office at the Insurance Division and the Health Policy Commission and CHIA, and we'll continue to do that work. I do think that there's an important inflection point in learnings from the market as to what the impacts are that folks on the ground are feeling, whether it's hospitals, medical providers, clinicians, or health plans. And the events are changing so rapidly that I think one of the nostrums in my mind is, let's make sure that we're tying back into those communities frequently and learning from them. The staff at the HPC already does a really good job of those connections and their research and reporting. But I also think that given the time sensitivity of the impacts, it'll be really important for us to bring that back even more in this current year. Thank you.
So moving forward, over the years, our statutory authority has grown, and the legislature has tasked us often with many reports and studies, and sometimes some new grant programs and opportunities. But the most significant change to our governing law happened earlier this year in January, when the legislature passed and Governor Healy signed two significant pieces of legislation, chapters 342 and 343 of the Acts of 2024. These are the most significant changes to our underlying statute and governing law since 2012, when the HPC was first established. These two laws have two, I think, motivating factors that largely shape the policy priorities contained within. The first is around the rising cost of pharmaceutical drugs. We have seen in our data that pharmaceutical costs have been one of the major drivers of healthcare costs over the last few years. And so the legislature passed a comprehensive piece of legislation, sometimes called the PACT Act, that included enhanced oversight of the pharmaceutical industry. And by that, it's kind of a broad term to include pharmaceutical manufacturers, pharmacy benefit managers, wholesalers, retail clinics, independent pharmacies, of the entire chain. It also includes some provisions around capping out-of-pocket costs for certain drugs for chronic diseases, and as I'll talk about, a very specific role for the Health Policy Commission. The motivating factor for the other piece of legislation was the dissolution and bankruptcy of Steward Healthcare. The state, having gone through the particular trauma of that bankruptcy and the closure of hospitals in Dorchester and Neshoba, realized and saw that there were needed changes to our law in terms of market oversight and an understanding specifically of private equity investment in healthcare. And so there's a lot of provisions within that law that also touch upon the HPC and our interactions with other state agencies in market oversight. So I'll kind of quickly touch on some of those changes. I will say, and you'll hear this again, we are still very much in the phase of implementing these new laws, and there is still much work to be done on implementing these new laws and even kind of the initial rules of these new laws. And that's going to be a big part of our work moving forward. So broadly, what are some of the things, other things that this did? It changed the HPC membership and appointment. It also revitalized state health planning. I'll talk about that. Enhanced interagency coordination, a primary care task force as well. All right. So first, let's start with the board. I think, as all of you know, this did make a kind of a full rechange of the HPC board and had a full reappointment process that took place in July. As you can see here, There were a number of the board positions that did stay the same, and there were some new and modified board positions. It did also change the appointing authorities and their respective appointments. I think you are all well aware of these changes. So first, let's talk about the new Office of Pharmaceutical Policy and Analysis within the HPC. This was a major provision within that Pharmacy PACT Act, as I mentioned before. Just so you all know, internally, we are calling this office OPA. Internally, we love acronyms at the Health Policy Commission. So we will give you a cheat sheet of all of our acronyms and how we pronounce those acronyms so that you can keep up with us. But we're calling this OPA. And really, this is a mandate from the legislature for the HPC to create a dedicated office and staff it to really be focused on analyzing and understanding what is going on in the pharmaceutical sector. And we will be able to analyze pharmacy spending data. We're going to be able to analyze data that our sister agency, CHIA, is going to be collecting from pharmacy benefit managers, and be able to produce reports and analyses and make policy recommendations on matters related to prescription drug policy. The mandate is quite broad, but also pretty flexible. So I think there is an opportunity as we stand this office up to be strategic and think about what are those areas that we want to start to investigate, to look into, where are those opportunities to make policy recommendations, to think about areas where there could be some real opportunities. And so it's an exciting new mandate, and we have already begun to staff this particular office. The law also directs us to do an annual report and to examine underlying drivers. It also requires us to do an annual report on the plan design, health plan design, and how health plans do kind of benefit design for pharmaceutical drugs. Expansion of HPC market oversight. You're going to hear a little bit more about this later, so I won't belabor this too much right now. But it does expand the types of transactions that can come before the HPC for review. You'll see that bulleted list on the slide. I won't walk through this. It also does expand our ability to collect information from significant equity investors and providers. Importantly, it authorizes the HPC to require additional reporting for a period of 5 years after the completion of a transaction so that we can assess post-transaction impacts. And otherwise also allows us to kind of more closely connect our market oversight work with that health planning work. The health planning work. This is the second new office that was mandated as part of this legislation. So again, a dedicated office within the Health Policy Commission, dedicated and focused to developing a state health plan. This is a 5-year planning period to identify, again, kind of need of healthcare services, providers, and programs, and analyzing what are those existing resources compared to need, looking at the supply and distribution, and again, where there might be misalignment. This is a huge undertaking. Many states have attempted to do this work, and we are trying to learn from other states about what is the best approach. There are some states who just kind of count how many beds you have and issue a report, and that kind of sits on a shelf. And so I think we want to be really thoughtful here about how we approach this and what's the best way that's going to provide value for the market, for the system, and for policymakers. We have also started to staff up this office and have started to do that initial thinking. But with both of these offices in particular, commissioners, I think we're really excited to get your input and feedback about what the priorities should be, and how we can continue to build this out. I'm skipping ahead. The legislation also establishes a new primary care payment and delivery task force. The HPC, through the executive director, is a co-chair of that task force with the Secretary of Health and Human Services. This is a 25-member task force charged with developing a series of policy recommendations to strengthen and stabilize our primary care workforce and delivery system and payment system. It has quite an ambitious charge, and we have been meeting regularly. We just had our 8th meeting of the primary care task force, or one of its work groups, just yesterday. And this is very relevant to the Health Policy Commission. The Health Policy Commission has repeatedly made recommendations around the need to increase the proportion of spend on primary care, around the need to invest in the primary care workforce. And so I hope to be able to continue to keep you all updated about the important work of this primary care and delivery task force. HPC staff, including myself, are really providing a lot of the support to this task force in terms of staffing it and providing the data and information and kind of background support, because this is so important and such a priority for the governor.
David, before you move into the benchmark, I just wanted to add something for the edification of the commissioners. The Office of Health Resource Planning, the Office of Pharmaceutical Policy and Analysis, the Primary Care Task Force, the Maternal Health Task Force, all of these things David has mentioned. While it's important that the legislature and the governor and everybody has codified these into law, and there's still a ton of work to be done that we'll be working with you all in upcoming years, these are not net new areas for the Health Policy Commission. And I think because we have a proven track record from our staff in all of these areas, that's a big reason why we were given these new responsibilities. So while there is a ton of work to be done, and we're thrilled to have the resource allocation and the codification of these responsibilities, just important to note that we do have a lot of expertise in all of these areas. So we're hitting the ground running.
Thank you. So I want to move on and talk a little bit about some of the work that HPC has done earlier this year, but happy to talk about any questions broadly on the new responsibilities. This is, as I said, going to be something we're going to be talking a lot about in the coming months. But Commissioner?
Yeah, more of a comment than a question, but I just want to emphasize, as we're moving on to other stuff, how important I think the work on overseeing private equity and for-profit, more generally, expansion into the Massachusetts healthcare marketplace, and how important a new role that is for the HPC. My organization has a lot of experience, not only with Steward, but with other for-profit and private equity interests in buying up our nursing homes. Our home care agency is owned by a for-profit. And I think there's been a lot of expansion in the marketplace all over the place, not just in union shops. So yeah, I just wanted to make that comment because I don't want that to be overlooked. I think that's a really important aspect of the law, which was passed in December, which I think everyone knows was partially, at least, in response to the Steward collapse and bankruptcy, and how important it is to, even if we don't have another big hospital system that's owned by a private equity company, there's still a lot of intrusion into the market and market dysfunction that those entities are causing. So I just want to emphasize that and encourage you and your staff to build upon that role as greatly as you can, and to, starting with the cost trends hearing, I'm hoping in November. So just want to make that comment.
Thank you.
I wanted to check in about the Office of Health Resource Planning, and seems like a big task. And I'm wondering who you think the audience for that is, who is going to be using that report, and how do we measure the kind of things we put out and whether they're being used by the right people, like the kind of impact that we have.
Yeah. So yeah, I think part of the motivation, and I think part of the place where that can be impactful, is through some of our sister agencies, and I think specifically about the Department of Public Health and the Determination of Need program. I think there is actually specific language within the law that as they're thinking about, projects that are going through that type of review, that they're thinking about how does that fit in within the context of a state health plan. And I think about that maybe two different ways, which is to say, you know, the way that the process sometimes works right now is that, you know, sometimes we look at each project individually, or even HPC, when we get a notice and we look at a market transaction, we're kind of looking at that particular transaction. And what the state health plan, I hope, will provide is kind of like, how do we put that particular transaction in kind of a broader picture, and to help kind of see the bigger forest from the trees? Because these little transactions may not look like much in and of themselves, but all of a sudden they can look, you add all of them up and suddenly it can look quite large over time. We did a report a few years ago just looking at kind of the pediatric market and how that has really consolidated over time. And it was a lot of kind of small transactions that kind of led to that place. And so as I think about what might those changes could be, there might be places where in our state health resource plan, we identify that there's a real need for some types of services and in some types of areas. And that may mean we want to help remove any types of regulatory barriers, or help incentivize the right types of policies to make those things, make the market want to invest in those types of services in those right types of areas. So I do think it is trying to influence market behavior, but I think how we can use the different government levers to help do that will go beyond the HPC.
Quick follow-up.
Yeah.
Thinking about, how do we think about exporting services? We're like a net export of medical services to other states. That's a big benefit for us as a Commonwealth, and jobs and resources that we get. How do we think about that export capacity in terms of thinking about this plan for state health planning?
That's a great question.
Think about, I guess it's a comment, not a question.
Yeah.
Question. Another question about the Office of Pharmacy Policy and Analysis. Can you say a little bit more about the realities of data that's available? In other words, seeing that we would produce an annual report, what's likely on the outlook in terms of when the first report might be produced and what time period that would look at? Do we have an outlook on that?
So we do think that we're going to have some interesting new data assets on that front, specifically through the CHIA data collection through pharmacy benefit managers. They are standing up that regulation now. I don't have a great sense of what their timeline is for kind of the initial round of data collection, when that will then be available for us to analyze. You know, I think with any time you do kind of the first time you do data collection, there is often some quality integrity issues that you'll need to kind of sort through. But that's not our only data source. We also have, of course, the all-payer claims database. There is, you know, significant information that we can mine from that. We are also looking and thinking about, there are often private data sources that you can essentially purchase or contract with, that can provide great insights into pharmaceutical trends and pharmaceutical pricing trends and things like that. So I think we're trying to be creative in terms of thinking about the different data assets that could help us get some insights, at least into identifying, okay, what are some therapeutic classes that we might want to focus in on, and to identify and to be able to create some interesting reporting on. We've hired an incredible leader for this office. I'm so excited for all of you to meet him. His name is Matt Frank. He comes to us from the FTC, and he has been thinking nonstop about the first annual report, and I think it's going to be 2026, but he is raring to go, and we're going to be able to do some really great work. I'll leave it at that. I don't want to set too high of expectations. Sorry, man. All right, well, we're going to keep moving. I just wanted to, before I kind of start to turn towards what we have going for the rest of the year, very briefly, just want to highlight that one of the most important roles that the commission plays every year is in setting the healthcare cost growth benchmark. And so each year, the commission meets in March and holds a public hearing in conjunction with the Joint Committee on Healthcare Financing. And we hear public testimony from a wide range of different organizations. We also hear testimony from CHIA and from HPC staff on data and information to help inform the board's decision about where to set the benchmark for the next calendar year. So this hearing was held in March, as I said. We presented a lot of different data. I've just picked 2 data slides here. This one is just continues to show that there is a continued affordability challenge in Massachusetts. I think we all know this, but the top 3 lines here are the growth in family premiums, employee contribution, family premium, employer contribution. And the blue lines are economic growth, median household income, and inflation. And clearly you can see the orange and red lines exceeding those other lines. And it's just, again, the outpacing of healthcare cost growth. And so this affordability challenge is very real in Massachusetts, and it matters to the residents and the people who live here. And because it does continue to eat out part of what their take-home pay is. And so we did this analysis to kind of try to estimate, like, how much is that and how does it compound over time? And so we did this analysis and we said, okay, let's try to forecast a future where we, if we were able to hold premium growth to 3.6%, very ambitious, of course, but let's just say we did. And then let's compare that to what it's growing at now at 7%. And let's see how much take-home pay is and what the difference is over time for an average family in Massachusetts. And you play that all the way out to 2030. And if you assume the 7% premium growth, by 2030, the average family is taking home $600 less a month than in that other scenario where the insurance rates grew at 3.6%. So these changes compound over time, and it just means less and less money in the hands of the residents who live here, who are already struggling with high housing costs, high childcare costs, high grocery costs. So this is our challenge, right? Affordability matters. We have to continue to stay on this. We heard a number of different themes from a wide range of different organizations at the hearing. Some were highlighting the rising cost of pharmaceuticals. Some were highlighting the uncertainty about federal policy changes, the need to reform primary care, the very real capacity and workforce challenges that provider organizations are facing. And some, of course, were highlighting that affordability challenge. Ultimately, the board did decide and voted to maintain the healthcare cost growth benchmark at 3.6% for next year, calendar year 2026. This board will need to be starting to think about this next year. We will be going through this same process again and determining the healthcare cost growth benchmark for 2027. So this slide here, this little spiderweb slide, this was a slide that the HPC board and I discussed at that April meeting, trying to reflect both what we heard in some of the testimony and also reflecting the new legislation, and tried to kind of articulate what are some of our overall kind of policy priorities and try to put this onto one slide. It was said at the time, you have 8 policy priorities. That's a lot of policy priorities. But we are working in a lot of these different spaces all at kind of the same time. So you can see here, affordability, workforce, pharmacy, primary care, unnecessary administrative costs, state planning, care delivery models. I think these are still, even now today in September, I think largely the things that we are spending most of our time working on. but I think as I think about the next couple of months and working with you and this next board, I think it's important that maybe we come together and maybe in January, we think about what are our priorities for 2026, and we maybe re-articulate what that is, and we do that both as a board and as staff together. But I'll pause here and just maybe if there's any reflections on this, if this still looks like the right overall buckets, and if there's things that now knowing what we know now, you would want to add to this.
I think it's a great start. I think it's a reflection on the things that are important to tackle, and then items that have been requested for the HPC to tackle. So it's a combination of items. You know, there's a subsetting of each of the categories that sort of fit under each other in some ways and certainly interact with each other. But as we dig in, I think we may benefit from a sense as a commission of prioritization of the priorities, less about taking things off the list, but more about where we want to concentrate our priorities given limited bandwidth and time and resources.
Yeah, and the only thought I'll give, it's interesting to see kind of the silos and the breakouts here, and these are clearly all very important areas. And I would just, as we go into those deliberations and conversations in the future, it'll be important that sometimes when you break things into silos, you forget why there's even spending in those categories in the first place, which is many of these are trying to improve health. So if you get caught in an isolation, we're just looking at a silo, everything becomes a zero-sum game, when in fact, there could be areas we just want to invest more in. And you can kind of get caught chasing everything instead of what are we really getting for the investments that we're making in these different categories? And that I think would be helpful for the Commonwealth to understand, like, what return are we getting for some of these large investments that we're making, as opposed to just, this is going up, this is going down. You don't often come to the right conclusions with regards to the impact that each of these investments are having. Some might be having quite large ones.
Thank you. Commissioner?
Yeah, I think based on the earlier conversation, we may have to also think about revisiting the discussion around coverage. We just may see a number of people losing their health insurance coverage, losing Mass Health, or being removed from the connector, as we've been reading about in recent weeks. And certainly we have expertise in the room, but there are other state entities and partners that we might want to be thinking about trying to get back to our best in the nation coverage numbers.
Great, thank you. Oh, yes, please, Chris.
Agree 100%, Steve. And it's something that HHS is wrestling with every day. And it is interesting. I like your comment about you can't take them in isolation, because you're right. I mean, if we've been analyzing the pharma trends over the last 15 years, and if you look at the piece of the pie, it's much larger today as a percent of the overall than it was in the late 2000s. But to what benefit? Yeah, exactly. So you can't take them in isolation. The one that stands out to me the most, and these are all important, but the one that we wrestle with every day is number one, consumer and employer affordability. And you've hit that one, David, a few times, but I just wanted to underscore it. It's one we wrestle with. I had a meeting earlier today. We've got meetings on a regular basis going through this. I know we all do, and a lot of us collaborate offline on this as well. So it'll be interesting to see how we can sort of divide and conquer, but look at these all in the context of the impact on the consumers we look out there. Thank you.
Yeah, thank you, Chris. And I think there's an obvious linking connection between that piece and coverage as we think about the potential loss of the enhanced tax credits on the marketplace and people losing coverage because they can't afford those products anymore, and what that will do to stabilize. And Commissioner, to your point, and I really appreciate that comment. And I think as I think about OPA and some of the pharmaceutical analysis that we're going to be able to do, I think we're in a really unique and good position to be able to try to think more holistically about that, because we have access to the all-payer claims database. And will it be able to kind of look more longitudinally at patients and see, yes, were they prescribed this thing, but then we can also say, what was their readmissions? What was their ED use? We can look at things, even a couple years down the road. What was their other medical spending costs? And that's, I think, speaking a little bit to your point, but having that access to not just the pharmacy spend, but the whole person spend, I think will be valuable. Great. I only have a few more slides, guys. And then we get to take a break. So looking ahead, what do we have on the agenda for the rest of this calendar year and into the first part of next year? Agenda item number 1. Welcome. Welcome to the HPC. I think we can put a big green check mark next to that one. And the next big priority that we are spending a significant amount of time on is continuing to hire, build these 2 new offices. It is not an insignificant amount of time and effort to hire and to hire the best people. And so I don't know, Colleen, if you want to say anything about that.
No, I think we've hit the ground running. Obviously, we have Matt Frank, who's our new director of OPA, and we promoted internally for the Office of Health Resource Planning is going to be led by Kara Vidal, who's been with us for over a decade at the Health Policy Commission and already has a really established career looking at some of these issues from the HPC. So hiring is going well for us for these and other open positions, given all of the changes that are happening in the federal government. So we've been able to hire from DC and from all over the country for some of these new responsibilities. So if anybody has any input into hiring, I welcome that at any time. So appreciate that. Thanks so much.
There are going to need to be some changes to some of our regulations that govern some of our work. We do our regulations through the board, so we will bring those to you. You will vote on them. We will then put them out for public comment. We will collect public comment. We will come back to you with any changes that we recommend, and the board will vote to approve those final regulations. So that is a process that staff and the commissioners will work together on. One is going to be updating our market oversight regulations. And here we're going to need to have some definitions around some of the new triggers for material notices to us around things like private equity investments, real estate investment trusts. And so we expect to go through that full public process and be able to collect good public comment on that. Another regulation that we will have to go through this process for as well is updating our budget assessment. So the HPC's budget is supported by currently an assessment on acute care hospitals, ambulatory surgery centers, and health plans. The budget, or the new legislation, expanded that assessment to include now pharmaceutical manufacturers and pharmacy benefit managers. As a result, we're going to need to update that regulation, which governs how we do that, and include those new assessed entities here too. We plan to go through a regulatory process, do that publicly so that the entities can understand how we're going to be calculating that, how we're going to be processing that. CHIA is also going to have to do the exact same thing, as they are also an assessed entity, exactly the same as HPC. So we'll be doing that in close coordination. And finally, we have a program that collects information from provider organizations that also was changed in the law, and we're going to need to finalize the set of data specs for that. And then that was all kind of related to implementing the new law. And then we have a bunch of other ongoing activities that are just a part of our standard work and things that we're constantly doing here at the HPC. I'll try to highlight some of the things that will be of particular interest to you as board members. So I'm going to start at the 2 o'clock handle research and report, and then kind of work clockwise. So we have a couple of reports that we do anticipate releasing before the end of the calendar year. One is a hospital at home policy brief. We actually released that today, and you have a copy of it in your binders. We sent it to you last week, and I'll share a couple of slides at the end of this meeting on that. Really excited to get that out. I think, as you'll hear, part of the impetus for releasing that particular report this month is that it is up for congressional reauthorization. The authorization for the Medicare approval of that program expires at the end of the month. And so we wanted to really highlight how that program has grown in Massachusetts and how the hospitals here have really invested a lot into growing that program. The second report that I'll mention here is our cost trends report. This is our signature annual report that we release. This is a statutory mandate that we release an annual report looking at cost drivers in Massachusetts. And so here too, this is something that we do ask for a vote of the board to issue that report. So we'll be sharing copies of that report with you for your input in the weeks and months ahead. And then finally, something that would be coming out sometime this fall is we are doing an analysis of what we're calling pharmacy deserts, which is kind of areas within the Commonwealth, geographic areas in the Commonwealth where there is a lack of access to a retail or independent pharmacy, and people are having to drive far distances to be able to access pharmacy, brick and mortar pharmacy. And so we've done some interactive mapping of that, and there have been some, recent academic literature and some recent media reporting around where there have been closures of some of these retail pharmacies and what are the profiles of those areas. On the partner front, I will just, I'm just going to highlight the second bullet, which is that we are currently implementing one new grant program. It is the Hypertensive Disorders Equitably Addressed with Remote Technology for Birthing People, Part BP. I told you we love acronyms. I told you. So this is a great program using, as said, remote technology to address hypertensive disorders in order to address serious maternal morbidity. We're working with 5 organizations: Berkshire Medical Center, Beverly Hospital, Edward M. Kennedy Community Health Center, Haywood Hospital, and Signature Brockton on this particular grant program. So we're just launching that, and that's going to be our grant program for right now. On the convening side, the main thing here is our annual cost trends hearing, November 12th. We're going to talk a little bit more about that towards the end of the meeting. And then on Market Monitor, I will just note that earlier this year, we did initiate a cost and market impact review, a retrospective review of the Beth Israel Leahy merger. When the Beth Israel Leahy merger was finally approved by the Department of Public Health many years ago, one of the conditions of that approval was that after 5 years, the department could request that the HPC conduct basically a 5-year retrospective review of that transaction to understand what has happened in that 5 years in terms of impact on costs and quality and access. We did receive that request from the Department of Public Health, and so we are very early stages of conducting that review. This is the first time we've done such a retrospective review. So not much more to say at this stage, but know that at some point we'll be talking more with you about that review. I'll pause here for any final questions or comments before we move to a break. So I guess I'd just say we have a busy few months ahead of us.
Terrific work, and really helpful to see it all synthesized. Can you comment on, in terms of the expansion of responsibilities, what does this mean for staffing and budget and just the realities of getting everything done?
So I will say that obviously state government and many state governments are facing a budget crisis. So we were lucky to get close to our budget ask for this year. So we're working within the confines of that to staff these offices, and hoping in future years we'll be able to really ramp up. But we're in a great place to be able to implement those responsibilities. We have hiring plans for 2 to 3 new staff for the new offices, and obviously we've been reassigning folks internally as well to support that. But we're in a good place, and we're in a good place also to hire expert consultants and outside contractors, which we've always done, especially in the new stages of our work. That's always been our sort of, build versus buy is always a question when it comes to resource allocation within the HPC and any public or private organization. So we're in a good place still for that, and I will report back if we're not. Doing great.
Madam Chair, just before we break, I know that I made you aware and Executive Director Seltz, but I have to speak at a conference shortly in Maine. So I apologize to fellow commissioners. I wanted them to know I made the arrangements prior to being named as a commissioner. I did check into the hotel last night. I made David aware, and I was in room 224. I don't know if I should be comforted or terrified by that, but either way, I apologize. I will have to leave at the break. But I would like the minutes to also reflect that had I been here this afternoon for the conversation, I would have recused myself from both the discussion and the vote on the Mass General Brigham CVS Caremark proposed affiliation. Thank you.
Thank you, Commissioner Walsh. Any other questions, comments? Well, with that, we're going to take a 10-minute break. We'll reconvene at about 2:30. Yeah.
It is.
Great. Thanks so much. We'll now reconvene and we'll move to the notices of material change that we have received since our last meeting. Turn it over to Kate Mills.
Thank you, Chair, and good afternoon, and welcome to our new commissioners. I'm Kate Scarborough Mills. I'm the Senior Director of our Market Oversight and Transparency team here at the HPC. So we are the team that analyzes changes to the provider market and their impact on healthcare costs, quality, and access. We also do the annual review of individual payer and provider spending performance relative to the state's healthcare cost growth benchmark, as well as a number of other things. And in the most recent year, we've been deeply involved in helping to stand up the Office of Health Resource Planning, under which we have now nested the state's Registration of Provider Organizations program, which is a data collection effort we run in concert with our colleagues at CHIA to collect data on the structure of the healthcare market in Massachusetts. So on the next slide, oh, perfect, thank you. Before we dive in talking about the recently received notices of material change, I wanted to just give a little bit of background on our transactional reviews generally and our role in this process. So as you see on the first slide here, the HPC was given the authority to track and review changes to the healthcare market in Chapter 224, which, as you heard, was updated most recently in Chapter 343 of the Acts of 2024, recognizing that the structure of the provider market and changes to that market, including mergers, acquisitions, and new affiliations, can significantly impact the ability of the healthcare system to deliver high quality, accessible, and equitable care. It can influence the prices that are paid for the care, the referrals, where care is received, the types of services received, utilization, and many other factors that can drive changes in spending. We were the first state in the nation to have a process like the material change notice and customer market impact review process, which is really a public reporting process that's distinct from regulatory oversight processes like the determination of need process at the state's Department of Public Health, as well as distinct from law enforcement reviews, such as antitrust reviews through our state attorney general's office. How this works practically is that providers are required to provide notice to the HPC if they have at least $25 million in net patient service revenue annually, and they are proposing to engage in certain types of changes. We then engage, and we'll go over those in a little bit more detail on the next slide, but then we engage in a back and forth with the entities proposing the change. And we can solicit confidential material, confidential data from those entities. that are exempt from public records law to make sure that we truly understand exactly what they are proposing to do. And then we conduct a number of detailed analyses to model likely impacts across a range of different factors. So for example, we might model changes in pricing based on pricing analyses in our all payer claims database, combined with the details of the terms of the deal, the details of in payer contracts and the terms of reimbursement. We might also model changes in market concentration using metrics like the Herfindahl-Hirschman Index, which is a measure of market concentration. And of course, those are just a handful of the types of analyses that we generally run. If after we complete a number of those analyses over the course of 30 days, we ultimately determine that a given change is likely to have a significant impact on healthcare costs or market functioning, we can recommend that the commission undertake a more robust review of cost and market impact review. During that 30-day review process, we provide notice to you, our commissioners, and to the public via our listserv. And we really encourage folks, we encourage our commissioners to reach out to us with any questions or comments or concerns about a given proposed change while we're engaging in that review. This authority exists alongside other market oversight authority at the HPC. So we have the ability to, for example, weigh in on filings made to the Department of Public Health through the determination of need process. And we also have the ability to now conduct retrospective reviews and see what actually happened after a change occurred. While we do not have the ability to approve or deny transactions, we do have the ability through these first-in-the-nation or investigatory processes to conduct detailed data-driven investigations and put out public reports that increase the transparency and accountability around these changes. And we have the ability through the process to ideally encourage market participants to maximize the potential benefits of any given change and minimize or mitigate any potential risks. So this next slide shows the transactions that are currently required to be noticed to the HPC. So on the left here, you see that providers have been required since 2013, provide notices to the HPC before engaging in the listed types of activities. So those include mergers, acquisitions, and affiliations with insurers, mergers and acquisitions with hospitals, any kind of affiliation between providers that is projected to increase net patient service revenue by one of the organizations by $10 million or more, as well as the creation of new contracting organizations and certain types of clinical affiliations between large organizations. On the right here, you see that the legislation that was signed into law at the beginning of this year added new categories of transaction that must be noticed to the HPC as of April of this year, which you heard about a bit earlier, namely significant expansions in capacity, changes in ownership or control of a provider that involve a significant equity investor, significant acquisitions, sales, or transfers of assets, including real estate leaseback arrangements, and conversions of nonprofit providers to for-profits. We put out some guidance to further describe these transactions back in March of this year. And then we expect to release a full rework of our regulations, as David noted, to fully incorporate these and other changes that were part of Chapter 343 in the coming months. So much of this notice and review process is really about transparency and accountability, as I noted, even in that initial 30-day review stage. The notices are publicly available on our website, and we publicly report, at least briefly, on all of the reviews that we conduct, even if we do not move to a full cost and market impact review. But at the end of 30 days, we do have a key decision to be made. If a transaction is anticipated to have that significant impact on the Commonwealth's ability to meet the healthcare cost growth benchmark or on the competitive market, we can launch the more detailed investigation called the cost and market impact review. That is something that our executive director is empowered to initiate, but the board must vote to affirm it at the next regularly scheduled board meeting if the timing doesn't align to do that at the 30-day mark. That cost and market impact review is designed to be a comprehensive review across many different factors, which you'll see detailed on the next slide. And it's designed to be broader and complementary to other review processes like law enforcement reviews and those at the Department of Public Health. When we conduct a cost and market impact review, we first publish a preliminary report. Parties have the opportunity to respond to it, and then we issue a final report thereafter, and the parties may close the transaction only after the publication of a final report. That CMIR report is generally a long and detailed report. It's generally 100-ish pages, and it can be used by others. It's a public document. It can be used by our sister agencies in regulatory actions, and obviously it can be used by the public, it can be used by other healthcare market participants, et cetera. Yes.
Question, and I'm going to use the mic this time. Do we have a sense of how often the Attorney General accepts a recommendation versus not, a referral, I guess, and kind of stats on, whether those reports are being used by other agencies?
I will say anecdotally, we know that those reports are being used because we get many, many follow-up questions as soon as they are published. Whether they translate into a direct regulatory action is a much more challenging question to answer. I will say that there are certain circumstances in which we are also required to refer reports to the Attorney General, and that may not always align with where law enforcement priorities might be.
I'd also add that the reports have the benefit of private market participants reviewing the conclusions or recommendations in data, and it oftentimes enters into private market conduct and negotiations between the parties. So it's helpful in that regard. The work is terrific.
This list of factors for our regulation that we can look at in our market reviews, both in full cost and market impact reviews, but these are also the types of things that we try to look at in even that 30-day process. Those range across many domains, as you see here: prices, spending, market shares and size, quality and care delivery, the role of organizations in serving vulnerable patient populations, providing needed and lower margin services, et cetera. And we analyze these transactions across these dimensions in close concert with teams of expert consultants. So not only the experts we have on staff here, but we also work with teams of contracted experts, economists, accountants, actuaries, care delivery and healthcare quality experts, and subject matter experts in various different fields, such as pharmaceutical policy and pricing. This entire process, when we conduct a cost and market impact review, is required to take no longer than 185 days, or as I mentioned, 30 days if it's simply the review of material change notice, noting, however, that any additional time taken by the parties to respond to information requests is also tacked on to our time at the end. But I do want to emphasize that it is always our goal to try to move as expeditiously as we can in our work. So we do strive to be on the low end of timelines. And so before diving into talking about some of the transactions we've recently received and those that we're currently reviewing, I do want to pause here just in case there are general questions about the process.
The health economist chimes in yet again.
Absolutely.
I'm curious, is there like a framework that's public for the structure of these reports so that parties would anticipate and know what's coming and how these are being evaluated, or is that kind of more bespoke to each unique situation?
I would say it's a little bit of a combination. So we have put out some general principles, and I would say that now that we've published 10 of these, folks can get a sense, looking at our past reviews, the types of things we look at. However, given that the individual drivers of spending changes, quality changes, access changes, equity changes as a result of any given transaction tend to be fact specific, there's always a degree of it that is customized to the transaction that's under review. So to dive into some of the things we are currently looking at. So first of all, this is just a standard slide we bring to every single board meeting to keep you, our commissioners, informed as to what we are seeing in the market. So since we began tracking in 2013, we have reviewed 192 different market changes. You see the frequencies listed here with changes involving physician groups continuing to be our most frequent, followed by formations of a contracting entity. I do want to note the very last category on this slide, ownership or control changes involving a significant equity investor. That is one of the new triggers under the new legislation, and we do now have a transaction that has been filed under that new trigger. So to update you on the reviews currently in progress, first, I do want to note, just as David noted, that we are currently conducting the cost of market impact review. That is a retrospective review of the impacts from the merger that created Beth Israel Lahey Health in 2019.
Sorry.
Yes.
Sorry to go back, but just to understand that, so 192 have been done. Is that 192 CMIRs, or that's 192 and you've done 10 CMIRs?
We've done 10 CMIRs of the 192 transactions that have been filed with us.
Thank you.
And I should note, those are completed CMIRs that we've conducted. So Beth Israel Lahey is number 11. So since our last board meeting in June, we completed review and did not recommend moving to a full cost of market impact review for 3 notices of material change. So I want to go over at a very high level some of our findings there. So first, the proposed acquisition of Vibra Hospital of Western Massachusetts, which is the for-profit owner and operator, both an inpatient long-term acute care hospital, as well as a skilled nursing facility in Rochdale, Massachusetts, by Everest Hospital LLC, which is a newly formed Massachusetts corporation in coordination with Neal Equities, which is a private investment vehicle with ownership interests in other nursing facilities. In our preliminary examination, we found a relatively limited potential for impacts on spending and market dynamics. Currently, both the SNF and long-term care hospital are somewhat underutilized, and Everest has plans that will ideally are designed to optimize the use of these facilities, increase the utilization a bit more. And though spending would be anticipated to increase as we see increases in utilization for those facilities, it's also important to bear in mind that that might also result in some savings as patients avoid or step down from more acute settings. We did not review evidence that indicated that the transaction is likely to negatively impact access or quality of care. And I'll note that this transaction is still under review by the Department of Public Health determination of need program. Second, we reviewed the proposed acquisition of River Valley Counseling Center, a nonprofit community-based mental health clinic in Holyoke, which is currently owned by Valley Health Systems, which is also the parent of Holyoke Medical Center. By ServiceNet, which is a nonprofit human services agency in Western Massachusetts that provides mental health, substance use, vocational, and other services. Here in our preliminary investigation, we found limited potential for impacts on spending and market dynamics, and the parties don't anticipate changes in their clinical services, and we didn't review evidence indicating that the transaction is likely to negatively impact access or quality of care. One have a question?
I
Yes.
did, and I wanted to return to the SNF private equity acquisition, because sounded like it wasn't going to affect market competition, but then you said something about not reviewing evidence that it would affect quality. I think there's some pretty good evidence that, I mean, in particular to the skilled nursing facility acquisition by private equity, that leads to increased mortality. And so I'm curious how you assessed that, and whether that's not big enough to justify a CMIR, or how you're thinking a little bit about that.
Yeah, so I want to caveat by saying that there is some limitation to what I can say in public board meetings based on the fact that we do receive confidential information that cannot be disclosed publicly, but happy to
chat offline in a bit more detail. I think it's important to note that the current owner was already a for-profit. And so while, yes, it is a private investment vehicle that is buying these hospitals, a lot of the details that we reviewed did not seem to be significantly changing structures that were already in place at these institutions. And the last transaction that we reviewed, completed our review of, was proposed contracting affiliation between Pediatric Physicians Organization at Children's, PPOC, which is a contracting organization partially owned by Boston Children's Hospital, and Children's Healthcare, which is a 9-physician primary care pediatric group with locations in Newburyport and Haverhill. That currently or previously established most of its payer contracts through the Steward Healthcare Network and later Revere Medical. Under the proposed affiliation, the CHC physicians would become participating PPOC providers, and they would join PPOC payer contracts under its independent physician association model. PPOC would also provide CHC with access to its pediatric primary care specific Epic system and related IT services. In our preliminary examination, we found limited potential for impacts on spending and market dynamics here, recognizing that based on analyses of the APCD, the parties' commercial prices for services were already pretty similar, and referrals from CHC were already going to Children's Hospital at a relatively high level. So simply the room for changes to those things in a way that would be impacting spending was relatively small. And at the same time, we also did not review evidence that suggested that the transaction would negatively impact quality or access to services. Any other questions about transaction reviews that we've completed before I move on? And so this simply lists the reviews that we are currently conducting. So first of all, we're reviewing a proposed joint venture between Milford Regional Medical Center, which is now part of the UMass Memorial Health, and Shields Healthcare Group. The JV would own and operate MRI and PET CT services in Milford. Second, we're reviewing the proposed acquisition of the parent entity of AmSurge, which is a private equity-backed owner and operator of 245 ambulatory surgery centers across the country, including 9 in Massachusetts, by Ascension Health Alliance, which is a national nonprofit health system and one of the largest Catholic health systems in the country. Third, we're reviewing the proposed acquisition of Kaba Fusion Inc., which is a specialty home infusion services company with locations across the country, including in Massachusetts, by a newly formed subsidiary of Nautic Partners, a private equity firm. And this is the transaction that, as I flagged, has been filed under the new trigger related to a change of ownership role involving a significant equity investor. For these 3 transactions, our review is still very much underway, and we will be in touch with initial findings as they become available. But finally, we wanted to speak in a bit more detail about this last transaction here, a proposed contracting affiliation. Oh, yes.
One quick suggestion that I think might be helpful, or you could at least illustrate to us how it's happening now, if because we're new, we may not know. This is great and important work, sort of burrowing down into the details per transaction. Pulling the lens back, tell us a little bit more about your trend analysis of emerging data across the market. So it might be helpful for us to identify for the commissioners and for further policymakers what you're seeing in terms of trends in the market over a certain time period, whether it's a year, 2 years, et cetera. And I know it's not within the purview of a specific transactional review, but pulling back the lens on filed transactions for material change notices and for CMIRs, it might be illustrative for us to see what the thread line is across the market in Massachusetts.
Great, yeah, we can absolutely bring some different cuts and in particular, in the past, have put out things, for example, showing how many transactions we've had in the state that have involved private equity and how that's changed. over
Particularly
time.
since we're doing some of the health system inventory work and planning work, I think this would be a really important data set for us to provide more detail around. And there's a theme here. You have the information. It'd be great to tell the story in a little bit more detail.
So the final transaction noted here is the contracting affiliation between Minute Clinic Primary Care, which is a physician-owned entity managed by CVS Management Support, a subsidiary of CVS Pharmacy, and Mass General Brigham. For that transaction, we are at the very end of our 30-day review and are recommending further action. But before I turn it over to Megan Wolf, who's overseeing that review, to walk us through that recommendation in greater detail, I wanted to pause to see if there were any other questions for me. Thank you, and over to you, Megan.
Thank you, Kate. As you probably already know, Mass General Brigham, or MGB, is the largest healthcare system in Massachusetts and one of the highest cost, with more than 7,700 employed and affiliated physicians, including 1,200 primary care physicians, representing approximately 30% of all physicians and 24% of primary care physicians statewide. It is anchored by 2 academic medical centers, Brigham and Women's Hospital and Mass General Hospital, and it also includes 9 owned community and specialty hospitals in Massachusetts, 1 contracting affiliate community hospital, a health insurer, MGB Health Plan, as well as community health centers, home health and long-term care services, and other health-related entities. It also owns a community hospital in New Hampshire. Its accountable care organization, MGB ACO, provides payer contracting, population health management, and quality improvement for its network of providers. 2 years ago, Mass General Brigham announced that its primary care physicians at Brigham and Mass Gen were no longer accepting new patients, underscoring challenges to primary care access recently highlighted by the HPC and the Commonwealth. CVS currently operates 37 Minute Clinic locations across Massachusetts, providing a limited scope of care, otherwise known as convenience care services, that are staffed by nurse practitioners. It also has clinics in 40 other states and the District of Columbia. CVS Minute Clinic's parent company also owns CVS Pharmacies, the CVS Caremark Pharmacy Benefits Manager, or PBM, and the health insurer Aetna. Minute Clinic's proposed shift to primary care in Massachusetts is a continuation of a model that CVS is rolling out in other states, including in Georgia, where Minute Clinic has partnered with Emory Healthcare Network to offer primary care services. Under the proposed transaction, Minute Clinic plans to transform from convenience care centers to Minute Clinic primary care clinics, which would offer comprehensive longitudinal care for adults across the 37 Minute Clinic sites in Massachusetts. Minute Clinic Primary Care would join MGB's Accountable Care Organization, or ACO, as an affiliated provider organization, participate in MGB's risk contracts, and have access to MGB's population health management infrastructure. The parties expect that approximately 80 advanced practice providers would begin managing panels of 1,500 patients each, creating capacity to serve 120,000 adult primary care patients statewide. The parties state that the APP-led model would improve access to comprehensive primary care by adding new sites of care and expanding access during evenings and weekends, offering convenient options for patients who might otherwise delay or forego care. The parties highlight a report the HPC released earlier this year, documenting challenges to primary care access and workforce sustainability, and argue that their proposed Minute Clinic primary care model would, 1, address statewide gaps in access to community-based primary care, including in regions with primary care access challenges that have high rates of avoidable ED use and primary care workforce shortages, such as Worcester County, Bristol County, and Western Mass. 2, would improve quality through their participation in MGB ACO, chronic disease, and population health management programs. And 3, would decrease spending by both shifting low acuity care to a lower cost setting with care provided by APPs and providing better chronic disease management, thus reducing avoidable utilization. HPC's preliminary review found that the transaction is likely to meaningfully impact healthcare spending. First, spending is likely to increase as the Minute Clinic primary care APPs join MGB risk contracts and receive MGB rates. Through an analysis of the all-payer claims database, we found that while APPs, such as nurse practitioners, do bill at lower rates than the corresponding physicians in a given system, the rates for Mass General Brigham APPs are approximately twice those of Minute Clinic's nurse practitioners for our major commercial payers in Massachusetts. Second, initial modeling suggests that as Minute Clinic APPs were to join MGB's risk contracts and utilize MGB's care network, there would likely be spending impacts from shifts in care patterns for the new Minute Clinic primary care patients, including a potential increase in referrals to high-cost MGB specialists. Further review could help us better understand where these patients would come from and how their care would shift under the Minute Clinic primary care model, helping us to better detail potential spending impacts. The transaction also has potentially important implications for quality, access, and equity. The addition of Minute Clinic primary care could lead to a much-needed increase in access to primary care in the Commonwealth, particularly for those who do not currently have a primary care provider. However, there may also be impacts on access to Minute Clinic's convenient care services as it transitions to primary care. Further review would allow the HPC to examine the impacts of the transaction on access and equity, including for vulnerable populations. Minute Clinic primary care is also a new care delivery model housed in CVS retail facilities. In light of the importance of and current emphasis on primary care access in the Commonwealth, a CMIR would allow the HPC to better assess the infrastructure and care delivery model being proposed, the degree to which it could provide the full scope of primary care services, and how it would integrate with the MGB network, and to make our findings public in a CMIR report. Finally, a CMIR would allow the HPC to explore the impacts of the Minute Clinic primary care model in other states to the extent that information is already available in order to inform projections of its impact in Massachusetts. So I'm going to stop there. That was a lot of information. I want to open it up for discussion, both on the merits of further review and the types of inquiries we might want to discuss in such a review if it were to go forward.
I'll jump in. I'm inclined to support further review. I think while there's certainly benefits towards the alignment, particularly in a time when we are having severe issues on primary care access for patients across the Commonwealth, I think it merits further understanding on the care model, for example. I think it's a fair question as to whether this modified primary care, not primary care in many respects. And while I think there's value to the alignment for the Commonwealth, I also think there are open questions on equity, including geographic equity in certain rural communities, Cape Cod, et cetera. As I understand the proposal, it's being launched at current facilities for CVS Minute Clinics and not an expanded service area. And I know that's outside the scope of what we could comment on, but obviously there are certain equity concerns that we may want to focus on in that regard. So I do think it merits further scrutiny.
Thank you, Commissioner.
So I would also support going forward with the CMIR, but I wanted to urge you and your staff to really think about the opportunity to look at this in the bigger picture that my fellow commissioner was talking about. Not only with the health resource planning lens in mind, but also with an an eye towards MGB and their many other expansions and affiliations, particularly in the outpatient markets. Yeah, I guess I'll leave it at that. I'm sure you will do that. But I think this gives you an opportunity to do a sort of a more in-depth review that includes some of those bigger considerations, putting this proposed affiliation into context, which I think is going to be very important going forward, particularly with the major players that are involved in this transaction.
Thank you, and absolutely agree.
I would agree with my fellow commissioners. I think the question here is, what is comprehensive primary care? And from my behavioral health perspective, particularly concerned with sort of the integration of primary care and behavioral health.
Mhm.
And I'd be curious to see what that looks like in Georgia and what that may mean for Massachusetts. So I would agree with the recommendation to do the full impact study.
Thank you very much.
I also echo my fellow commissioners and getting doing the additional review. Also, in terms of diagnostic, you talk about specialty referral patterns, but also what happens with services like lab, radiology, and diagnostic that are not in these sites, and what does that mean in terms of referral patterns and cost as well, and factoring that in as part of the review.
Absolutely. Thank you, Commissioner.
I would also agree. I believe that some further evaluation is merited. But with that said, we also agree access to primary care has been an incredible challenge in the Commonwealth. So that is something from Health and Human Services we've been monitoring and pushing. And Secretary Mahania is on the primary care task force. The governor in her state of the Commonwealth last year, primary care was front and center. So access, equity, affordability are front and center for us, underpinned by those vulnerable populations and mass health, making sure that there's some coverage that occurs there. But further review, but again, in measure, if it's going to give us better access to that primary care, that's a good thing. We like that.
I'll echo and enhance the previous statements that it seems like this is worth investigating further. I would suggest thinking about whether these clinics will be paid at the same rate as other MGB advanced practice practitioners, and wondered whether we could get data from Georgia, whether to see how are they being paid at the same rate as other Emory providers, et cetera. That might be helpful.
One follow-on, I'm thinking about the Georgia question. Do we know how long they have been rolling out this model in other states? Is this something that's been around for 3-5 years, or is it 3 to 6 months? I don't know. I don't have a sense of that.
My understanding is that Georgia began at the beginning of this year. So I think we're probably looking at most about a year of experience.
Thank you.
One other comment would be, as you do the evaluation, obviously netting out in some ways increased or decreased utilization for the services and where those services would have gone is an important question. It's hard to land that in many ways. So it's not just the price conversation about what the services would be priced at, but what are you avoiding in terms of where the care would have gone for the patient population that you think we're estimating would go to the new facilities or newly constituted facilities.
Absolutely.
Or even referrals for higher level care.
Yeah, specialty care referrals as well.
Other questions or comments? Any last comments from you, Megan, before we move to vote?
Have brief comments on a couple of slides before the vote, but we can go very quickly. I know we're a little bit behind. So Kate went over some of the details about what a CMIR would entail, and I just wanted to provide a little bit more detail on what such a review would include.
So if this transaction were to move to a CMIR, the HPC would request data and documents from the parties, payers, and other market participants, including potentially data in Georgia, conduct in-depth analyses with the support of our external consultants, and solicit feedback from you, our board. As in our preliminary MCN review process, all non-public information we receive in the course of our review must be held confidential, although if we proceed to a CMIR, it may be disclosed in a CMIR report after a balancing test. The CMIR process results in the release of a preliminary report, which the parties then have 30 days to respond to, and then a final report, which may include a referral to the Attorney General's office or other state agencies. I think I'll skip over this slide, just a repeat of what Kate mentioned earlier, but we have a broad group of factors to consider in our review, including any factors in the public interest, which gives us discretion to look at a, transaction by transaction at what's truly important. And as Kate mentioned earlier, the CMIR process is envisioned to take 185 days. So we're now at the 30-day mark. So it could take about 155 more days to get to a final report if the parties provided all requested information within 21 days. And we would endeavor to move as expeditiously as possible, although much of the ultimate timeline will depend on how quickly the parties could get us data and documents. And with that, I will turn it over to Executive Director Seltz to lead us through a vote.
Is there a
our
proposed closing date for the alignment or transaction date that the parties have identified?
I think they're hoping to have it wrapped up as soon as possible. End of the year.
Yeah.
End of the year. Yeah.
I do think, as you've outlined, the care and attention towards the productive feedback back and forth with the parties in terms of meeting those goals would be really important.
Yeah, I'll just say to that point, the conversations with the parties have been very constructive to date, and we expect that to continue. And our commitment is to move expeditiously.
There questions or comments? Seeing none, can we move to a vote? Can I have a motion to, as listed on the screen? Second? All in favor, aye.
Aye.
All opposed, nay. Any abstentions? Approved. Thank you. We'll look forward to next steps. We will now move to our executive director's report. I'll turn it over to Director Seltz.
Thank you, Chair DeVoe. Just before we move into the executive director's report, I'll use my prerogative as executive director and as co-chair of the primary care task force to just say a few words on this last vote. It was mentioned many times, but earlier this year, the HBC did release a state of primary care in Massachusetts. We titled it "The Dire Diagnosis, the Declining Health of Primary Care, and the Urgent Need for Action." We do have an urgent need for action to fix primary care. We need action to increase the proportion of our healthcare spending in primary care. We spend 7 cents of every healthcare dollar on primary care, and that number is going down. We have an urgent need to fix the administrative burden in primary care. For every hour of clinical care, there's 2 hours of administrative work that primary care clinicians do. We need urgent care action to fix the pipeline in primary care. Among states, we have one of the lowest shares of new physicians choosing to go into primary care in Massachusetts. We need to change how we reimburse for primary care to incentivize team-based care and to integrate behavioral health into primary care. And these are some of the topics that the Primary Care Task Force is really focused on and looking at. And just having had a meeting of the Primary Care Task Force yesterday, that task force is really focused on coming up with a lot of ambitious policy recommendations for the legislature and the governor very soon. And I'm really heartened by the commitment of that 25-member task force to find consensus and to be able to move that forward. Just on the transaction that was before us, I appreciate the innovation that they have there. I do think we do need new ideas to provide high quality, affordable primary care that is accessible to all residents, regardless of income and insurance type. And I do think the HPC's further review will help us enable to understand if this proposal meets those goals, and to really be able to provide objective information to the public. So thank you for your support on that. We can now move forward to the Executive Director's report. Hi, Colleen. So first, very pleased to share that we have just issued a new research publication from our research and cost trends team. This is a project that they've been working on for many months over this year, highlighting a new clinical model. Well, not totally new, but a growing and emerging clinical model, which is called hospital at home. And so we have conducted this research to really try to first just explain what this model is, how it's grown in Massachusetts, and to be able to provide some considerations about how the state, policymakers, and the market may want to continue to consider as this continues to grow. So we've just released this brief. It's on our website, and encourage everyone to go check that out. I'm just going to highlight a couple of findings from this report now for your edification before we turn to some other matters. So what is Hospital at Home? Hospital at Home is a program that provides inpatient level care in a patient's home rather than in the traditional brick and mortar setting. While Massachusetts hospitals were early leaders in this model of care, these programs have expanded dramatically across the country when CMS launched the Acute Care Hospital at Home program for Medicare beneficiaries back in November 2020, largely due to help with capacity issues during the pandemic. Currently in Massachusetts, there are 8 active hospital at home programs with 20 total hospitals approved by CMS for one of these acute care hospital at home waivers. Congress does need to approve that acute care hospital at home waiver to be able to, for Medicare to reimburse hospitals for this level of care. Currently, they have passed multiple reauthorizations of that waiver, but it is set to expire at the end of this month. And so without congressional action, that will expire and Medicare will no longer be able to reimburse for this type of care. This is really important because, as we found in our study, the majority of the patients in these programs are Medicare patients. They have done this reauthorization many times, so I think there is an expectation that they could do so again. But as we sit here today, it is September 18th. And so we felt the timing of releasing this report was important because we do think that this is a really promising clinical model. Our hospitals have invested significant time, resources, and energy in building up these programs, and we hope that there's congressional action soon. Part of what we hope to do in this brief is really just be able to provide an understanding to the public and maybe to a more lay audience about what is hospital at home. And we often get questions about what is hospital at home versus like home health care. And in short, it's important to say that hospital at home is a hospital benefit for people who need hospital level care at their home. Home health care is a short-term home benefit that mainly provides nursing services and rehab care, such as physical therapy. It is a vastly different scope of level of care. And this table really kind of lays that out. And we talk a lot more about this in the report. We also talk in the report in detail through our hospital discharge data, the number of patients that have used this new benefit. So the number of hospital at home discharges has increased almost tenfold from 2020 to 2024. It was about 460 back in 2020 to now about 4,500. It's important to note, though, in terms of overall hospital discharges, it's a pretty small amount. It's still less than 1% of all inpatient discharges. As you can see, it was dominated in some of the early years by a couple of hospitals, MGH, Brigham and Women's, and UMass. But there have been entries of a number of other hospitals in more recent years, and community hospitals have also joined the program. Finally, we include in the brief a number of kind of policy considerations to track and to understand as these programs move forward. One is around appropriate admissions to ensure that these are continue to be used for the appropriate patients, the appropriate level of care. To be thinking about how these programs, as they grow, may impact and help alleviate hospital capacity challenges. We think there's other appropriate research that could be beneficial in understanding what are the appropriate payment rates for this level of care. There's a need for some standardization of data collection, and also a need for the Congress to approve this waiver and continue this program. So I hope you check out this policy brief. I shared it with commissioners. If you have any questions, I will turn it over to the staff to answer those questions.
David, I had one question, and I want to channel Wendy Everett, the original vice chair of the commission, who always said, look at rehospitalization rates in 30 days. I didn't see any rehospitalization rate data in the report, but that may be something to think about in future reports.
Yes, I think we were challenged a little bit with this particular report due to, frankly, a pretty small sample size in terms of the data still. So I think this is an area where even like, I would say in maybe a year, 2 years, where we have a bigger sample size, a bigger data set, we'll be able to come back and look at some bigger questions.
And can you say more about what Congress would reauthorize if it is reauthorized? In other words, they would extend the amount of time for the waiver, or they would more permanently make this a benefit under CMS? I guess, any of the above?
Unknown. I don't know. They have done these kind of more short-term 1 year, 2 year extensions. This has grown. This has been across the country. This is not just Massachusetts. This is a priority for the American Hospital Association. I don't know of any opposition to this. It's both popular with the hospitals, popular with patients. CMS did a kind of an evaluation, an early evaluation. It had very positive results. Patient experience results were positive. You know, for many of these patients, being in their home is a real benefit. There are questions about this and who is being, who's appropriate for this. But I think our general sense is that this should continue, and we should continue to learn and collect more data and continue to evaluate.
Thanks. I wanted to say, thank you for this report. I think it's a very important and emerging area, which is very promising to both save money and provide better care for people. There's one comment, which is that sort of buried in there is the issue of Mass Health not being able to pay for duplicative services, particularly personal care attendants, for people who are discharged to a hospital at home. So that limits the ability for Mass Health patients generally to be able to take advantage of this program. I do worry a little bit about sort of creating a two-tiered system where Mass Health patients end up staying in the hospital longer than they need to, or that is affordable. And wealthier patients are able to hire private home care or otherwise find some way around that issue, have their insurance company pay for it. I know that the hospitals have been working on that, and in some cases I've even just decided we'll just continue to pay for a PCA. They only cost $20 an hour. They're quite cheap for the hospitals to hire, and for Mass Health. But I do think it's an emerging issue, and I think it's something to keep monitoring to avoid creating some sort of new service that's not really for Medicaid patients.
Just to piggyback on that in terms of, because you're right with the report, which I thought was really nicely done. I enjoyed reviewing it. it did speak to some exceptions being made for aides or PCAs, but as you look at appropriateness of admissions, also looking at standards of care and what those look like, so that there is consistency, that everyone who has, whether it's asthma or whatever, is getting the same level of care, the same resources and services and support, not just those that can afford. So that's, I think, creating those standards may also support consistency and equity.
Thank you both for those comments.
Great. Okay. In case your takeaway from your first meeting was, wow, we have a lot going on. Let's move on to large scale public events. We also do those. So I am very pleased to preview with you all today that the HPC's 13th annual healthcare cost trends hearing will happen on Wednesday, November 12th at Suffolk Law School in downtown Boston. For commissioners who may not be aware, the purpose of this annual hearing is to examine the drivers of healthcare costs and discuss opportunities for improving care and reducing costs throughout the Commonwealth's healthcare system. The format is really unique. It's not quite a conference. It's not quite a hearing. We have the ability to call key stakeholders under oath to give live testimony to you all and under questioning from you all in a public format, generally in a panel format. And as I said, we've done this for 12 years. This will be our 13th, and it's really a seminal annual event. It sets the tone not only for the HPC's work for the year, for the cost trends report, our policy recommendations for the year, but also generally health policy making writ large in the Commonwealth. So given the passage of the 2 landmark healthcare laws we've talked a lot about today, this hearing obviously offers a really critical opportunity to discuss all the pressing challenges that we've been talking about, particularly amid the looming federal funding cuts, and the impact of federal policy changes will certainly be a main theme of the day. So interestingly, the new laws include new testimony from additional market participants that we haven't been able to call in years past. So we're able to call this year significant equity investors. We're able to call real estate investment trusts or REITs. We can call MSOs, management service organizations. We can call PBMs, and we can call pharmaceutical manufacturing companies. So that's all new for this year. It also adds other state agencies who've certainly come to the hearing in the past and participated with us in the past, but the legislature felt it was important to add these folks in statute. So it's Mass Health, it's the Health Connector, it's the Division of Insurance, who I think we're covered on. And then it's folks from CMS as well. So those are all added to our witness list of people we're able to call to testify. So we're really looking forward to opening up the conversation. We'll have more updates for the board soon on themes and panels and experts that we're calling. Registration is coming soon, and also the summons to testify for everybody watching on the live stream. That is also coming soon as well to an inbox near you. Any questions about the hearing? The agenda will be posted to the website too. Great. Okay. Next up, I also have an announcement about the HPC's Advisory Council. This Advisory Council is appointed by the Executive Director. We constituted in 2013. It really gives us incredible amount of input and insight into our research agenda, our policy initiatives, our investment programs. We've had it on hold for the past few months. We last met in February 2025. We've had it on hold for the past few months as we've been awaiting our board appointments. There was some overlap between the board appointments and the Advisory Council, but we are reconstituting the Advisory Council this fall. This is really a broad cross-section of healthcare participants, stakeholders across Massachusetts. It's a really diverse body. So we're excited to put it back in place. Again, the new laws also added a few people that we have to appoint to the Advisory Council. So we do have to appoint pharmaceutical manufacturing companies and PBMs as well. You'll see the mirroring of the new laws mirrors the constitution of the new board, mirrors the constitution of the new advisory. Very thoughtful. So we'll be putting that in place soon. We'll be consulting you all on that. Will be really helpful as we're standing up OHARP and OPA and all of our new responsibilities. Really recognize this important group of healthcare leaders We've been so blessed to have these folks help us over the past 13 years, and we really value their experience and expertise. So we are going to do a new process for folks to express interest for the advisory council, and we'll be rolling that out very soon, forthcoming. So on everything I've said, watch this space and more to come, but did want to give an update on those two important responsibilities. And I think with that, I will turn it back over to Madam Chair for final remarks and update on the schedule.
Thank you. Yeah, we wanted to review the upcoming board meetings. The board will next convene on Thursday, October 23rd, and then our final meeting of the year will be on Thursday, December 11th. But as we've been, discussing, we will also have the November 12th cost trends hearing. Any other questions or comments from commissioners? Yes.
Those board meetings are virtual, the October and December.
October 23rd is virtual, and December we'll talk with commissioners and see what the preference is about convening either virtually or in person.
The November 12th hearing, can a commissioner be called to testify in the capacity of their day job? Not as commissioner?
That's a great question.
That's why I asked it.
You in that, I think. Lowest question. That's me first.
That could apply to multiple commissioners.
That's a slippery slope.
Right. Boy, a new world,
Is there even?
new world.
We have a lot of discretion on who we can call.
Good questions, thoughts?
Great.
We are
great start.
officially launched.
Great.
Thank you, commissioners, and thank you to those tuning in on the live stream and to the whole team at the HPC. And we are now adjourned.
Thank you.